best in radiology.
At its core, coronary artery disease is where you get hardening of the blood vessels that give blood supply to the heart muscle itself. And that often starts off with just a minor degree of narrowing, but over time can progress to a point where it's actually preventing sufficient blood supply to the heart muscle when it exercises. And people can often feel that when it becomes severe as having chest pain, or what we call angina. So a CT Coronary Angiogram, which is sometimes shortened to CTCA, is a test that we use a lot these days in the domain of chest pain. Historically, the way we would try and investigate whether there were narrowings and blockages in the heart artery was, or still is, the gold standard is to put a catheter into the artery and push it all the way up to where the heart sits and where the arteries take off and supply blood, and using that catheter to very gently push some contrast through into each of the arteries and take X-ray pictures. And that is a very important and good test, but obviously the trade-off is that it's an invasive study. And what we've found is that we can take similar pictures, but with a CT scan that then doesn't require a catheter inside the body, and instead injecting the contrast in through a little plastic tube in the arm and then taking pictures as the contrast hits the artery, and that shows up the vessels quite nicely, and you can then look for that hardening in the arteries and see to what degree it has started to narrow the vessels. One of the things that people worry about is going to be a painful test, and the beauty of a CT test is it doesn't really have any of those sort of worrying aspects like having big catheters put into you. It is a painless test which takes literally just a few seconds and is all over and done with then. So the key information that the CTCA will give to your doctor if you're having chest pain is whether there are detectable narrowings that could be causing that interruption of blood supply that can cause chest pain on exertion. But it also goes one step further. It gives a lot more information, not just about significant narrowings, but also other narrowings which are in the process of development. And we really understand now that it's not just the amount of blockage of a single narrowing, it's about how much plaque there is in the entire coronary tree. And that information, whether you look at it in terms of a verbal description or a calcium score, also comes with the CTCA. And that's very important information because one of the important things about these sorts of tests is not only telling you if you don't have heart disease, for example, but if you have heart disease that's in the process of developing, and yes, it might not be the cause of the chest pain right now, but what can we do to prevent it becoming a problem down the future as well? It's a really good question, which is the best test for heart disease, and I think my best answer is if there was a best test, we would be using that test on everyone. And actually we have lots of different tests which are all really good at testing the heart in different ways, like stress tests, nuclear tests. I think the reason CTCA has become so widely used is partly not just because of that fact it tells you about existing narrowings, but also about the atheroma and the plaque that's present elsewhere, which you don't really get with other tests. And there's actually been some studies, clinical studies, showing that that information can actually make a real difference downstream in terms of how likely that person is to be free of heart disease, because you've picked things up early, irrespective of whether you were actually having chest pain from heart disease right there or then or not.